there should be a reason, no?
Because, may I just say something, because Dr. Bock is a gentleman and, you know, it's called professional courtesy. They're scared of it because they don't know anything about it. Let me just say something. We had a professor of pediatrics come into our office crying with a 2-year-old. And he asked me, what do we do with him? Now, he's a professor, so can you blame the doctors out there? They actually don't train very much on autism. This is a new disorder. In the 5-7 years they spend in the university, they only spend 1 day on autism. And what they're actually learning something from probably textbooks that are 20 years old. That is the problem.
I'll answer it a little bit, a little differently. No, I'll let Dino's got his opinion, which is good. The problem is multifold. Number one, the evidence, it does not meet the level that they would say they require. Like, remember I showed you the food additive and hyperactivity? Because that study came out in 2007, September, now they'll say, oh yes, food additives and preservatives do cause hyperactivity. Do you think in 2006 food additives and preservatives didn't cause hyperactivity? Of course it did. But they would deny it right up until the time that double-blind placebo-controlled study comes out. The problem is evidence-based medicine is very, very helpful. But you know, when evidence-based medicine came out, it wasn't only randomized, large, double-blind placebo-controlled studies. The only people that can fund those usually are pharmaceutical companies, hundreds of millions of dollars. Evidence-based medicine, there's different levels of evidence. And part of it, when it first came out, definition-wise, was clinician experience. I have experience with way over 2,000 kids, right? So there's something I have from that experience that is very, very helpful. So when I see a kid, I have a sense of what might help or work, and I go in a certain direction. It may not be verified by a double-blind placebo-controlled study, but does that make it wrong? Of course not. That evidence was supposed to be valued, but what's happened is, and I think this is because of pharmaceutical, it just maybe, I don't know, that a lot of that has been devalued. The case control studies have been devalued. A lot of the evidence except double-blind, it's almost like if it's not double-blind placebo-controlled, it doesn't matter. And that is a problem because you're not going to get companies to do large double-blind studies on B6 or methyl B12. I mean, you're starting to get a few smaller ones in this field because there's getting some money for research. That's number one. The other problem is it's not one intervention. It's interwoven. It's very complex. So a lot of times you do one thing, it's not going to do what it does in the context of the whole thing. That's number two. And I think Dino was right. They're not trained. And the model, the medical model, the integrative medicine model that I use, I spend an hour and a half with a new patient. So I really get into the details, right? Because the details mean a lot to me, because that helps me subgroup, helps me figure out where I have to go. How many of you probably have spent an hour and a half with a physician? Yeah, it doesn't happen. Insurance doesn't cover it. That's the problem. So we're out of insurance. So there's an expense involved. So I've created a foundation to try to help kids who can't afford it because there's an expense involved. But the American model, and I think it's the same as the model here, is you see a kid for 7 minutes. Here, I think it's even less, right? What do? You see him, you figure out what's happening, give him medicine, on to the next. You cannot do autism with that model. You just can't. I could never do it. My follow-ups are anywhere, maybe 40 minutes, then a half an hour, then maybe 20 or 30 minutes. It can't be less if you're doing supplements and diets and medications and the whole works. You can't. So unfortunately, the modern medical model does not fuel this. And the truth is, it's very difficult for an office. It's not cost-effective for most doctors. And it's very, very difficult and a headache. It's a lot. So they rather not, I hate to say it. You have to be most of the doctors in this field entered because they had autistic children. I got into this probably around 1998, 99, at the end of the 1990s. So I was one of the few. There might have been 2 other doctors in this field at the time that didn't have an autistic child. Almost every other one had it because it was self-serve. They wanted to help their kids. So they got into all this, and then they just started helping other kids. So it's a long-winded answer, but I hope it explains it. It's unfortunate. It's changing. INSEPT has a lot of support behind it, and we're going to try to reach the mainstream. My scientific advisor, my board is small but very, very respected. My scientific advisory board is very respected. There's a conference that was supposed to happen in June on prevention and prediction. And it was all with academicians from major medical centers. And when I'd been told by somebody I was the only clinician involved because I'm really heading up this whole INSEPT. So I think there's a lot behind it. I think they want to up the standards of care. And that's our job, is to do the training, certification, and credentialing. So I think the future will be brighter. We hope to train more and more family docs and pediatricians around the world, in person as well as via the internet and webinars and all kinds of things. So, but it's going to be a while.
Next. Anybody?
What is your opinion on Ritalin, Strattera, and antipsychotic in the treating autism and ADHD children?
So Strattera,
Ritalin, and this SSRI and this antipsychotic treating.
well, sometimes you need them. I mean, what we find is sometimes when the kids come out of the spectrum and they lose the diagnosis of autism or PDD, they're left with what I would call as recalcitrant ADHD, very difficult ADHD, that they may not respond to diets, may not respond to the natural needs, and they need a medication because that's what's preventing them from really going all the way. So we sometimes will use those medications. I like, there's alternatives. I don't love Ritalin because there's more side effects. Strattera can cause side effects but can sometimes be helpful. The SSRIs in some kids with anxiety and OCD can be very helpful in the right kids, but they can also cause side effects. So you have to get it right. But even sometimes a very tiny dose of an antipsychotic like Abilify, which is a very tiny dose that might not cause side effects, may just take the edge off, may balance the neurotransmitters. So there is a place for medication sometimes. It's not, it should never be the only treatment, but it can be a treatment while this approach takes traction, or when a child is coming out of the spectrum and is left with this recalcitrant, persistent, very difficult to treat ADHD. Sometimes the medications make a huge difference. That attention, that decreased anxiety is all it takes to almost normalize them. And then you have to weigh the risks and benefits. So I'm not anti-medication, but I'd much rather do it naturally and safer, but we need them sometimes. You're welcome.